This program is brought to you by Emory University.
All right. Well, good morning, everybody. Happy Friday. Last Friday before Thanksgiving week. So not surprisingly, we will not, no one's shocked to hear we will not have Friday conference next week for the Thanksgiving holiday. We'll have, as you can see, we have a journal club today. Our first presenter is Dr. Ryan Cousins. Ryan's a second-year fellow in the clinical track, did his residency here at Emory, and he is going to talk about the MULTISTARS AMI trial. Ryan.
Thank you very much, Dr. Williams. Thank you, everybody, for joining us today for the Friday Fellows Conference. I'll be going first. So I'll be talking about immediate exit stage left, the MULTISTARS AMI trial. I have no financial disclosures or conflicts of interest with the presented material in this presentation. We'll first start with the clinical vignette that I made up. So pretend you are working in the emergency department shift and you realize as a 65-year-old male comes in with uncontrolled hypertension, diabetes, A1C is 11.5, hyperlipidemia, tobacco use disorder, or all the coronary vascular disease risk factors, comes in with acute chest pain that started 3 hours prior to presentation. You get an EKG within 10 minutes of arrival that demonstrates essentially prominent ST segment elevations with Q waves in V1 through V3. You've also got reciprocal ST depressions in the inferior leads, and you think this is consistent with anterior STEMI. And so you do the left heart catheterization, and essentially demonstrates a 99% proximal LAD thrombotic lesion. You go ahead and do aspiration thrombectomy, you restore TIMI-3 flow, put 2 drug-eluting stents in there, and determine that this was the culprit lesion for the presentation. While you're also in there, though, you also noticed that there was an 80% first diagonal stenotic lesion, 90% proximal left circumflex stenotic lesion, and the RCA had 30% but non-obstructive lesion in that territory as well. So essentially, the clinical question then becomes, for patients that are presenting with hemodynamically stable acute ST segment elevation myocardial infarction, and they're found to have indexed multivessel coronary disease, what is the optimal timing to actually undergo complete revascularization of these other non-culprit lesions after you fix the STEMI lesion? And that's what the investigators of this trial were trying to determine and figure out. Just some context in some previous trials. So as we know, in patients presenting with STEMI, multivessel coronary disease is actually fairly common. Roughly 50% of these patients will have more than one vessel with significant lesions within there. And then we know these are associated with an increased risk of recurrent MI and death. And this is supported by several trials here within the past 10 years. And current ACC-AHA guidelines, among these are RCTs as well, do support us doing complete revascularization for these patients that present with acute STEMI, found to have multivessel disease, because this significantly reduces the risk of cardiovascular death, MI, and ischemia-driven revascularization at 1 year. And these primarily came from the PRAMI, culprit, and complete trials that were performed in 2013, 2014, and 2019, respectively. And the BioVast trial, which was actually asking a very similar question to the MULTISTARS AMI trial, essentially found a similar conclusion that we'll come to, but they ended up doing patients who had any form of ACS, including STEMI and STEMI unstable angina, whereas the MULTISTARS AMI trial specifically focused just on patients with STEMI. Our focus has pretty much shifted from if we should fix these non-culprit lesions to when. And of course, like we mentioned, the timing of when it's optimal to fix these non-culprit lesions is still unknown. And these are the current ACC-AHA SCAI guidelines that mention in terms of revascularization of the non-infarct artery in patients with STEMI. It's a class 1A recommendations for patients that are hemodynamically stable with STEMI and multivessel disease after a successful PCI to the culprit lesion to go ahead and fix those non-infarct arteries in a staged process. But it's actually a 2B recommendation currently for patients, again, similarly presenting that are non-complex and hemodynamically stable, that you can fix the other non-culprit arteries in the same index procedure. And that 2B recommendation was what the investigators were trying to look into a little bit more as well. That brings us to the trial that was done in October, published on October 12th, 2023 in the New England Journal of Medicine, timing of complete revascularization with multivessel PCI for myocardial infarction. This was an investigator-initiated, multinational, open-label, randomized, non-inferiority trial that was performed at 37 sites that were all in Europe and mostly in Germany. So the patient recruitment occurred from October 2016 to June 2022, and the tail end of the patient recruitment and trial period did end up going through the kind of height of the COVID pandemic that sort of influenced some of the results in the recruitment and the kind of ability to have some of the stage procedures be done in a fashion that they would have liked, and we'll get to that in a little bit later. And last but not least, this was supported by Boston Scientific, but they had no role in the trial design, analysis, interpretation of the data, or writing of the manuscript. So the next few slides go through the inclusion and exclusion criteria. I know there's a lot of text on the slides here, but I think it's always important to know what patients qualify, which patients don't qualify, to know exactly what type of patient population we're dealing with in terms of comparisons. So for the inclusion criteria, we had patients that were, of course, 18 years of age or greater. They had to have a spontaneous acute STEMI presenting within 24 hours of symptom onset. These patients had to be suitable for a PCI from either the femoral or mostly the radial access, and their coronary artery distribution had to be suitable as well for the Synergy PCI stent implantation that the investigators chose for the PCIs. They had to be able to specifically identify with confidence what the culprit lesion was. And the non-culprit arteries that they were considering in terms of revascularization had to be greater than 70% stenosis in at least 2 different projections, and had to be a diameter of 2.25, between 2.25 and 5.75 millimeters after a mandatory dose of intracoronary nitroglycerin. The ACT, of course, had to be greater than 250 seconds with IV heparin. We had to establish TIMI-3 or TIMI-2 flow after revascularization of the culprit artery. Patients had to be hemodynamically stable throughout the procedure and post-procedure, had to have no evidence of shock. And lastly, had to be on DAPT for at least 90 days post-PCI with the recommendations of at least 6 to mostly 12 months in this trial. Even more text with the exclusion criteria. So I won't necessarily spend time going through all of these per se, but again, it's important, I think, to know which patients were not included. Of course, they had to have informed consent. They could not be in cardiogenic shock. They could not have had prolonged resuscitation in the field for greater than 10 minutes before presentation. If they were unsuitable for PCI, if they had a previous CABG, needed an emergent CABG, coronary dissection, if they had stent thrombosis, if they had an allergy to the stent material, either severe complications of the acute MI as well, so any like severe valve dysfunction, ventricular free wall rupture, etc., they were excluded. They did not have significant renal failure with an eGFR that needed to be greater than 30. No CTOs in this trial or chronic total occlusions. No significant left main disease or left main equivalent. No in-stent restenoses, no other planned coronary or cardiac surgery. Again, make sure they had no contraindication to DAPT, and had a life expectancy essentially greater than 1 year. This is the patient flow or intention to treat analysis. So won't spend too much time kind of flying through this, but essentially starting from top to bottom, roughly nearly 3,000 patients were screened, and about 1/3 of these end up meeting criteria to go ahead and participate in the study. Only about 840 underwent informed consent, and so roughly about 420 in each arm were designated to the immediate multivessel PCI group in the left, and versus the stage multivessel PCI group in the right. And you see the various reasons in terms of why patients, after they were randomized, were not able to fulfill the sort of the protocol based upon how they were allotted. But the vast majority of the patients were able to have at least 1 year follow-up and remained alive. 12 patients had died by the end of the 1 year follow-up in the left arm here for the immediate multivessel PCI. A total of 11 patients died on the right hand with the stage multivessel PCI, with 5 of them dying before their stage multivessel PCI was scheduled and 6 later on after they had their staged procedure. This is essentially a very similar graph, but this is more in terms of the protocol per protocol analysis. So the top of the graph top of the flow chart is essentially the same. But again, we have various reasons as to why, once they were both randomized in terms of the immediate and staged group, why the patients either were not able to go through with the per protocol analysis or not. Most importantly, there were about 10 patients from the immediate multivessel group that end up going and crossing over to the stage multivessel group for various different reasons, but there were no crossover from the other side, from stage to immediate, naturally. But again, most were able to be allotted into the per protocol analysis as well. The primary endpoint was essentially a composite of death from any cause, non-fatal myocardial infarction, stroke, unplanned ischemia-driven revascularization, and/or hospitalization for heart failure within 1 year from the index STEMI, PCI, and randomization. But a whole slew of different secondary endpoints here as well, which I won't necessarily go through each one individually, but you can read them on the screen for ones that are interesting to you. But we'll also spend most of the time in terms of the secondary endpoints going into the individual components of the primary endpoint as mentioned above. We'll spend some time discussing the results of acute kidney injury between the two different groups and different composites of all-cause death, cardiac death, and non-fatal myocardial infarction here too as well. Briefly going through the definitions, these are important. So the definition of myocardial infarction was defined based upon the third universal definition. And the criteria for this was essentially a detection in a greater than 99% percentile of the upper reference limit of the cardiac troponin CTN with the addition of at least one of the following. So symptoms of ischemia, new ST segment elevations, T-wave inversions, or new left bundle branch block, pathologic Q waves on the EKG, or imaging evidence of new loss of viable myocardium, or identification of intracoronary thrombus by angiography. Briefly jumping into the baseline characteristics for all the different patients, with the characteristics on the left and the immediate group and stage groups here on the right. So the median age for these patients is roughly the same, around mid-60s. It was a patient population that had 3/4 to even more in terms of the male sex predominance. And the vast majority of these patients were Caucasian or white as well. In terms of the medical history, they kind of balanced out fairly well with regards to cardiac disease risk factors, as you can kind of see here, in addition to their former or current smoking history here as well. So in terms of presentation, there were kind of small numbers in the immediate group and stage group with regards to needing resuscitation before hospital arrival and left bundle branch block. But importantly, kind of highlighting on the bottom here, this was the location of where the myocardial infarction occurred. And when you tally up these numbers in the immediate group and stage group with regards to percentage, the percentage is actually greater than 100. And so they only divvied these out based upon 4 different anatomic locations of the myocardium, but did not necessarily substratify or group together patients who were deemed to have anterior lateral or inferior lateral MI, for instance. And we'll discuss why that was kind of important later on. With regards to the culprit lesion, moving on to the second table of procedural characteristics. So fairly quite evenly split with regards to the LAD versus the RCA being the culprit lesion about 40% of the time for each, with the left circumflex making up the vast majority of the rest of that as well. And the location of the non-culprit lesions. So importantly, the LAD for both groups was actually encompassed about 50% of the non-culprit lesions for both groups, which we'll discuss why we think that's important later on here too as well. And then the bottom of the screen here, about 80%, give or take, had at least one non-culprit lesion, with about 20% having 2 or more. About 3/4 of the patients in both groups ended up having radial artery access. That also followed suit for the stage procedures as well. The use of either anatomic or functional periprocedural assistance to guide whether we should stent the non-culprit lesions or not was left up to the operator's discretion and was actually used fairly minimally in terms of the immediate, a little bit more in the stage group. But collectively, like FFR, IVUS, OCT wasn't quite used as often. The stents for each patient that were used were equivalent essentially in the immediate and stage groups at 3. Total stent length, fairly similar here too as well across the board. Volume of contrast material was higher in the stage group compared to the immediate group, with the lower end of the confidence interval here for the stage group kind of incorporating towards the middle of the immediate group, but this was not statistically significant. Similarly, duration of fluoroscopy was also in the same kind of boat there too as well. And the duration of the procedures similarly followed suit, with again the stage group having higher or longer in terms of duration of the procedure and shorter in the immediate group. The time from index procedure to stage procedure was roughly 1 month, and we'll discuss that the investigators that actually did not determine or explain why they chose the stage interval to be around 37 days. We'll discuss that a little bit later here too as well. And then last but not least, the hospital stay was just roughly 1 day longer for the stage group, understandably. With regard to the results, for the primary endpoint, which again was a composite of death from any cause, non-fatal myocardial infarction, stroke, unplanned ischemia-driven revascularization, or hospitalization for heart failure, 35 patients in the immediate group had an event that fell into this bucket at the end of 1 year, while 68 patients had that in the staged group. So the treatment effect for this was 0.52, and this was statistically significant. And on the next slide, we see more of the kind of Kaplan-Meier curves with regards to the time to event for both of these groups. At the bottom, you'll see the axis from 0 to about 365 days, and the cumulative incidence on the left-hand side here too as well, with a blow-up of the splitting of the curves a lot earlier on, kind of close to the 50-day mark here. And as we mentioned before, the risk ratio for this is 0.52, which ended up becoming or coming out to have a p interval less than 0.001, specifically for non-inferiority, which this study was looking at. But they also concluded that this was less than 0.001 in terms of a p-value for superiority here too as well. Again, important to mention that these curves split out fairly quickly with regards to roughly about the 30 to 45-day mark. Another busy slide that essentially goes into some subgroup analyses of the primary endpoint, with the variables on the left, the incidence of these of the immediate group and stage groups in the middle, and a forest plot on the right-hand side with regards to whether they favor the immediate group or the stage group. And none of the variables favored the staged group, but there were a couple different variables here that I think were important to note. When we mentioned before the infarct location of the STEMI or the culprit lesion, when that was the left circumflex of the RCA, which was then fixed, and then based upon just the protocol, if there were LAD lesions that were non-culprit lesions, those were fixed as well. And so you can see that that was statistically significant when the STEMI groups were the left circumflex or RCA, but it crossed over to 1 when the LAD was the culprit lesion and was fixed. And then the number of vessels with relevant non-culprit lesions as well. When you had 2 or more, which again, that was only about 20% of the population for both groups, while the confidence interval for this was, of course, larger than the 1 for just 1, it's still kind of trended towards and was statistically significantly less than 1 in terms of favoring the immediate group here as well. Wrapping up with some secondary endpoints here. Again, what they did was they broke down the composite primary endpoint into individual characteristics here too as well. And so death from any cause, stroke, number 3 down, and hospitalization for heart failure, 5th down, were not statistically significant between the 2 groups. However, non-fatal myocardial infarction and unplanned ischemia-driven revascularization were statistically significant. And they specifically defined unplanned ischemia-driven vascularization as anything due to anginal symptoms, new ischemic EKG changes, or signs of reversible myocardial ischemia on non-invasive imaging. And importantly, the other variables that they briefly mentioned were target vessel revascularization, lesion revascularization, stent thrombosis, acute renal insufficiency, major bleeding, and procedural success, which they also defined as attainment of less than 20% residual diameter stenosis by visual assessment and either a TIMI flow 3 or 2 after the procedure. But importantly, I wanted to highlight the acute renal insufficiency variable here. So this was actually not statistically significant between the 2 groups of immediate versus staged. I know that's one of the variables that we consider as well with regards to, trying to save the contrast load for patients with in terms of kidneys with regards to immediate versus stage. We'll discuss that a little bit too. So in conclusion, the investigators mentioned that for the primary endpoint, which again was that composite of these different variables here, among patients in hemodynamically stable condition with STEMI and multivessel coronary disease, immediate multivessel PCI was not inferior to staged multivessel PCI with respect to the risk of death from any cause, non-fatal myocardial infarction, stroke, unplanned ischemia-driven revascularization, or hospitalization for heart failure at 1 year. In addition, when you do the secondary endpoints, individually, non-fatal myocardial infarctions and unplanned ischemia-driven revascularizations were also statistically significantly lower in the immediate group versus the stage group. It's particularly important that this curve split out right around the 45-day mark after randomization. So just mentioning some discussion and critiques. So the investigators mentioned a few different things with regards to theory as to why we might have seen these differences, especially earlier on, with regards to the results of the immediate versus the stage group. And so they mentioned that unstable plaque features in the non-culprit lesions in these STEMIs patients may confer a predisposition to plaque rupture, subsequent coronary events, when the PCI of the non-culprit lesions is actually performed as a stage intervention. In addition, they mentioned that improved coronary blood flow in the non-culprit vessels, once we do the immediate multivessel PCI, may in theory reduce the ischemic burden that's common during the early phase of a STEMI event and then towards better outcomes. And then this was a little bit not as a definitive conclusion, but they also just briefly mentioned that, you know, when we do the immediate multivessel PCI, this in theory or potentially, even though this wasn't statistically significant, but kind of trended toward the immediate group, favored, you know, less contrast volume, less radiation exposure, that hopefully can lead to reduced risk of worsening kidney function and shorter hospitalization, cumulative length of stay. But that wasn't necessarily significantly seen. So as I was going through this article, I did have some remaining questions that I want to look into. I didn't necessarily find the answers for, but as we mentioned, you know, I think it's important to note that patients where the non-culprit lesion was in the LAD and their STEMI was in the RC or left circumflex, as we saw from the forest plot, that this drive outcomes that favored the immediate group. Because of course, as we know, I mean, the LAD is one of the most crucial coronary arteries. And so if we leave a significant lesion in this area to do a staged procedure 30 days or more afterwards later on, well, that may confer a little bit of a greater risk in terms of driving those results. In addition, in a similar vein, for patients that end up having 2 or more significant non-culprit lesions, which likely potentially would also include that LAD, you know, should we favor doing immediate, is that why immediately done for those patients favored compared to staged when they had more of an ischemic burden? Does that favor the immediate group here too as well? Why did they choose an average of 9 to 45 days for doing the stage procedure for the STEMI culprit lesion? Wasn't quite clear. Sometimes, you know, we thought that maybe choosing the 4 weeks or 30 days on average was from the immediate procedure. Well, was this just a per protocol basis where we have to monitor for post-procedural complications and then we can do the stage procedure? It wasn't quite clear. And then as we briefly mentioned, they didn't have patients that were in cardiogenic shock or had end-stage renal disease. But there's a pretty decent difference between having an eGFR that's, you know, just above that at 35 or greater than 60 and vice versa for ejection fraction. So they didn't necessarily substratify based upon that. And last but not least, they didn't necessarily mention, you know, not all STEMIs are created equally with regards to the specific location of the STEMI. They did the coronary distribution, but not whether it was proximal, mid, distal of these vessels, and how much of the infarcted myocardium was at risk in terms of the index PCI. Briefly mentioning some limitations. So initially they tried to acquire about 1,200 patients for the study, but the enrollment for this was actually going pretty slowly. And so they actually included heart failure, hospitalization, and stroke later on after the protocol was initiated. And so they're wondering if this lended towards a bias towards non-inferiority, but the events for heart failure, hospitalization, and stroke are very minimal between the two groups. So they said that that still probably did not kind of sway the results quite as much. Again, this was also kind of toward the tail end during the COVID-19 pandemic. So patients that were in the staged arm might have been even delayed a little bit more because of the logistical challenges during that time as well. And they also mentioned a little bit that there might have been some ascertainment bias toward difficulty discerning procedure-related myocardial infarctions in the immediate group versus the stage group, like a type 4 MI situation. And of course, most important, or very importantly, this had a very small percentage of women, and individuals from different races or ethnicities. So the generalizability of this study, especially for our patient population, it's not necessarily equivalent in terms of that. Lastly, just some future directions. So it'll be very interesting to note if these results are very similar for patients that come in with STEMI, but have other variables that were initially excluded, such as cardiogenic shock, left main disease, CTOs, previous CABG, or stent thrombosis or in-stent restenoses. Do these conclusions still hold? If we had the staged PCIs done a little bit earlier than the 30-day average, would we find either a sweet spot or kind of similar results if we shifted the days and when the stage procedures could be done? And again, as I mentioned previously before, it was up to the operator's discretion whether they used anatomic or functional assistance with regards to kind of helping with which lesions were actually significant from a like I said, anatomic or flow functioning standpoint. So whether we included this more in terms of the protocol, would this kind of change outcomes here a little bit as well? And last but not least, as briefly mentioned on the previous slide, kind of broadening these, this study to a greater patient population. I want to thank Dr. Sajja for going through this presentation with me and the article and making sure that we, were able to critique this as we needed to and kind of make sure the conclusions we came to were sound and, everything made sense in terms of how we would be able to apply this data moving forward. And these are the references for this presentation. Thank you for taking the time to listen to this talk.
Thank you, Ryan. Couple quick minutes for discussion here. My question is, and maybe you mentioned this, so I'm sorry, were the patients blinded during this study or no?
I believe so. So this was open label.
Yeah. I mean, because part of it is obviously a lot of this was driven by return with anginal symptoms. So, just psychology of patients. If you're in a study and it's like, hey, you're in the group where we didn't fix everything, and you're at home waiting on your staged PCI. Now, of course, a lot of patients would come back with ACS, which I don't think would be all that related to as much related to psychology, but I could see where folks getting readmitted with chest discomfort, knowing that my stage PCI is 37 days from now, but I'm having little twinges of chest pain after my single vessel PCI, and how much that played into it. But anyway, just a thought. Any thoughts, Ryan, either from you or from the audience on this study? All right, but yeah, an interesting study certainly, and like you said, probably the key phrase is in hemodynamically stable. Non-shock patients that certainly would suggest that going ahead and fixing other lesions seems to be a reasonable approach. If the operator deems it necessary or deems it feasible. So. All right. Well, very good. Thank you, Ryan. Appreciate it.
Of course. Thanks, Dr. Williams.
Our second speaker is Dr. Aparna Sajja. Aparna she's a third-year fellow in our clinical track, slated to be one of our EP fellows next year, did a residency at Johns Hopkins, did a year of fellowship at George Washington before transferring in for seeing the light and coming here to Atlanta as a second-year fellows. And she's going to talk about, I forget the name of the talk, but AFib ablation trial. So Aparna, take it away.
Thanks, Dr. Williams. Thank you, everyone, for joining. So I'm going to be discussing pulsed field or conventional thermal ablation for paroxysmal AFib. So this study, the Advent study, was published this August in NEJM. And basically looks at pulsed field ablation and comparing it to conventional thermal ablation. So what is pulsed field ablation, or PFA? So PFA is largely non-thermal energy approach. So unlike RF or cryoballoon ablation, it uses high voltage electrical fields for electroporation, and it causes irreversible destabilization of the cell membranes, which leads to cell necrosis. And unlike current ablation modalities, PFA can be used to more selectively target myocardial tissue while attempting to avoid injury to nearby structures, particularly the esophagus and phrenic nerve. So compared to the other modalities that are widely used, radiofrequency ablation that involves point-by-point application of thermal energy around the antrum of each pulmonary vein, this can typically be a bit more time-consuming. And then cryoballoon ablation involves freezing the pulmonary veins, and it more so developed out of a desire for faster ablation strategy that would be more of a single shot, durable kind of approach. And there are several studies that compare the efficacy of RF versus cryo, and many of them have found them to be comparable. And recently there have been some that have shown cryo to be more superior than RF. So thermal energy, and this is lumping together both radiofrequency ablation and cryoballoon ablation, is more indiscriminate, and the effects might extend beyond the myocardium to adjacent tissues. So potential complications of these ablations include atrioesophageal fistula, which is exceedingly rare, less than 0.1% of cases, hemidiaphragmatic paralysis, which it can be up to 0.4%, and then pulmonary vein stenosis. So in this study, there have been prior non-randomized single-center clinical studies that have shown favorable safety and efficacy for pulsed field ablation when used for AFib. So this is the first study that really compares pulsed field ablation with conventional thermal ablation, so either radiofrequency or cryoballoon ablation, in treatment of drug-refractory paroxysmal AFib. So for the methods, the authors, this is a multi-center randomized non-inferiority single-blind trial with blinded endpoint adjudication. This was done in the US across 30 centers and roughly 65 operators. The adults were under the age of 75 years of age with symptomatic paroxysmal AFib that was refractory to at least one antiarrhythmic drug. And then after treatment of 1 to 3 roll-in patients per center to ensure that the operators were familiar with the PFA catheter, all the subsequent patients were randomly assigned to 1-to-1 ratio to undergo either PFA or thermal ablation. And for the thermal ablation group or the control group, this was either radiofrequency or cryoballoon ablation for each control group. So here the patients didn't know which group they were assigned to. In terms of inclusion and exclusion criteria, so looking at the inclusion criteria, we're looking at paroxysmal AFib, so that terminates spontaneously or with intervention within 7 days of onset. Also those with recurrent paroxysmal AFib, so 2 or more episodes within 6 months. They've failed antiarrhythmic treatment, and then ages 18 to 75. And looking at the exclusion criteria, and there are many more as well, but these are some of the highlights. If they've had 4 or more cardioversions in the past 12 months, they were excluded. If their left atria were severely dilated, they were excluded. Any prior atrial ablation procedure other than right-sided CTI ablations or right-sided SVT ablations were excluded. Any prior atrial surgery, if they had a left atrial appendage closure device, or if they were slated to receive one in the near future, they were excluded. Significant valvular disease, congenital heart disease, if they had a pacemaker, ICD, or CRT device, they were excluded. And then if they had NYHA class 3 or 4 heart failure, and with EF less than 40%, they were excluded. So looking at some of the procedural characteristics, so they used a Boston Scientific FARAPulse PFA catheter. So that was delivered over the wire to each pulmonary vein using a sheath. For the procedural endpoint, the authors were looking at entrance conduction block of all treated pulmonary veins after 20 minutes of watching period. Oral anticoagulation was continued, and then class 1 or 3 antiarrhythmic drugs except amiodarone were permitted during the initial 3-month blinking period. All patients were followed for 1 year with telephone calls at 7, 30, 60 days, and then office visits at 3, 6, and 12 months. For arrhythmia detection, they used a 72-hour Holter monitoring. This was performed at 6 and 12 months. And then they had EKG recordings weekly after the blanking period and for any symptoms. And then they also interestingly looked at the anatomical features of the pulmonary veins using cardiac CT and MRI at 3 months. And then in a subgroup of patients, they actually looked at brain MRIs within 48 hours of ablation to assess for silent cerebral lesions. And then these were their endpoints. So the primary endpoint was freedom from a composite of initial procedural failure to achieve pulmonary vein isolation with use of the randomly assigned treatment method only, documented atrial arrhythmia lasting 30 seconds or longer after the initial 3-month blanking period, use of a class 1 or 3 antiarrhythmic drug, or cardioversion after the 3-month blanking period, use of amiodarone at any time, repeat ablation at any time during the 1-year follow-up period. And then the primary safety endpoint was a composite of pre-specified device and procedure-related serious adverse effects within 7 days of the procedure. And then of note, atrial esophageal fistula and pulmonary vein stenosis were included as serious adverse events regardless of the timing of occurrence. And then secondary safety endpoint was change in the pulmonary vein cross-sectional area between baseline and 3 months. So for their statistical analyses, the sample size was determined adaptively through a Goldilocks design. So at specific enrollment milestones, 350, 450, and so forth patients, the predictive probability that non-inferiority would eventually be shown for each primary endpoint determined whether the enrollment should stop, either for high probability of trial success or futility. And so ultimately they stopped at 550, the data from 550 patients met stopping criteria. So looking at this flow sheet of the patients, so initially 741 patients were assessed for eligibility and 35 were classified to have screening failure. And then of those patients, ultimately 626 patients comprised the intention to treat population. 19 withdrew before the procedure. So then we're left with 607 patients that were includified in the modified intention to treat. And then once the roll-in phase was completed, which included a total of 80 patients, the remaining 607 patients were randomly assigned in 1-to-1 ratio to undergo either pulsed field ablation or conventional ablation. And then of those 607, 583 ultimately completed the trial, with 12 of the patients from each group prematurely exiting the trial. And so in the end, 305 underwent PFA and 302 patients underwent thermal ablation with follow-up at 12 months. So again, the years that the study was done was 2021 to 2022. This was done in the US. We went over the numbers in the prior slide. And then at 1-year follow-up, of note, 16 of the 299 patients who underwent PFA and 22 of the 292 patients who underwent thermal ablation were taking class 1 or 3 antiarrhythmic drugs. So looking at the authors table 1, we see that the ages are pretty comparable between both groups. There's a mean age of 62 years. Roughly 66% were male in each group. The cohort was predominantly white, greater than 90%. The mean CHA2DS2-VASc score was 1.7. And then the years since the first diagnosis of paroxysmal AFib was roughly more than 3.5 years for each group. And then pretty much 100% of the patients were on anticoagulation and 99% on antiarrhythmic drugs at the start of the trial. So looking at the actual treatment characteristics between both groups, the mean procedural time was roughly 106 minutes for PFA and 123 minutes for thermal ablation. Overall success of pulmonary vein isolation during the index procedure was roughly the same between each group, 99.6% and 99.8% in thermal ablation. Electrical reconnection of the pulmonary veins during the 20-minute waiting period was 4.4% in the PFA group, 5.5% in the thermal ablation group. And then CTI ablation using RF energy to treat atrial flutter was performed in 23% of those who had PFA, and 28.5% who underwent thermal ablation. So looking at the endpoints of the 305 patients who underwent PFA, 204 had treatment success. And of the 302 patients who underwent thermal ablation, 193 had treatment success. So the estimated probability of treatment success was 73% for PFA and 71% with thermal ablation. And the procedure-related serious adverse events occurred in 6 patients who underwent PFA and 4 who underwent thermal ablation. So PFA met criteria for non-inferiority as compared to thermal ablation. And overall, the outcomes in the two groups were very similar. Ablation resulted in improvement in quality of life without really any apparent in between group differences. And then the repeat ablation was performed for clinical recurrence in 14 patients who underwent PFA initially and 20 who underwent thermal ablation at 1 year. And then the durability of the pulmonary vein isolation in patients who underwent a repeat ablation was 64.8% per vein with the PFA group and 64.9% per vein for thermal ablation. So this is the Kaplan-Meier survival curve for freedom from a composite of the initial procedural failure to isolate the pulmonary veins using the treatment method only, the atrial tachyarrhythmia, so that includes AFib, flutter, or any kind of ATAC lasting more than 30 seconds after the initial 3-month blinking period using a class 1 or 3 antiarrhythmic drug, or cardioversion after the 3-month blinking period using amio at any time or repeat ablation at any time. And you see that the groups look the same. There's really no statistically significant difference between the endpoints here. In terms of the mean change in the cross-sectional area of the pulmonary veins, with the PFA group, it was very small, 0.18 centimeters, and then 1.8 centimeters with the thermal ablation group. And in the past, it's been thought that there is some narrowing of the pulmonary vein ostia with the thermal ablation. That is pretty typical with the procedure. And this is kind of an interesting endpoint where they're comparing both of this between the groups. So the probability, again, was very similar between our PFA and then those who underwent RF or cryoballoon ablation in terms of treatment success. And then looking at the complications, so 2 of the patients who had PFA had tamponade, 1 who ultimately died. And then in the brain MRI sub-study, 3 of the 33 patients who underwent PFA and 0 of the 30 patients who underwent thermal ablation had asymptomatic ischemic phenomena. And then there was persistent phrenic nerve injury in 2 patients who had cryoballoon ablation. And this kind of highlights, again, some of these complications. So these findings support other PFA work that was published this year. There's a seminal trial, Pulsed AF, that evaluated the 12-month efficacy and safety in a population of patients with paroxysmal and persistent symptomatic AFib. This was in May of 2023, basically looking at treatment success at 12 months for paroxysmal AFib, and then treatment success at 12 months for persistent AFib. And then the findings in this study in particular are consistent with prior retrospective non-randomized single center studies comparing PFA with RF or cryoballoon ablation. So this is a 2023 CIRC paper, which looked at 400 patients who underwent PFA and cryo-based PVI, and basically found 100% pulmonary vein isolation in the PFA group and 98% of the cryoballoon ablation groups. The median procedure time was shorter in the PFA group, similar to this study, 35 minutes for the PFA group, and cryo was 50 minutes. And again, the success was defined kind of in this study as freedom from atrial tachyarrhythmias after a 3-month blinking period. And overall, the Kaplan-Meier curve showed no statistically significant difference between both groups for paroxysmal AFib and persistent AFib. So limitations of the study, of course, so they use a 72-hour Holter monitor at 6 months and 12 months, and the episodes of asymptomatic recurrence of AFib may have been missed as they didn't use continuous monitoring. Follow-up was limited to 1 year. The authors looked at a single PFA catheter technology in patients with paroxysmal AFib only, so it would be interesting to see what this looks like for persistent AFib and some of the other technologies out there. And I thought the Goldilocks trial design was also interesting. It's commonly used in the real world, but nonetheless, it seems to set up some bias as to when to stop enrollment. So all in all, bottom line of the study is that PFA was non-inferior to conventional thermal ablation with respect to the primary endpoint. And in terms of outlook, the trial will be used to support the approval of the FARAPULSE system in the US, where there's currently no widely used PFA systems available, unlike Europe. And there will need to be longer term studies in terms of looking at persistent AFib with PFA and other types of patients who might benefit from one technology over another. And these are my references. I'm happy to take any questions as well.
Thanks, Aparna. I guess my question's just clarification. You mentioned sort of the safety, potential safety benefits of PFA. Is that sort of just theoretical, or is that based on smaller other studies, animal, like what you mentioned without, less esophageal phrenic nerve injuries, et cetera? Because I know this trial probably wasn't necessarily designed to look at that. It was just sort of looking at sort of major stuff, but sort of what was that based on?
Yeah, so I think that it was based more so on earlier studies and not necessarily comparing PFA versus the thermal ablation technologies necessarily, because the study didn't really have any significant there is one phrenic nerve injury or atrial esophageal fistula. I think it's really mainly based off of theoretical stuff. I'm not sure if there's other animal work that compares both.
But clearly this shows, right, that in terms of efficacy of the stated goal of ablating AFib, it seems to be equally effective to other methods.
Correct.
Correct. Certainly without an increase in no obvious increase in complications. So, all right, well, good. Any comments, questions?
Aparna, Stan Sherman. I noticed that they measured the pulmonary vein and whether the pulmonary vein decreased in size, and did more so with thermal versus the pulse field ablation. Do we know that has any meaning, in terms of follow-up? Or they went to the trouble to measure it. Does that have some clinical problems in the future and that sort of thing?
Yeah, that's a good question. So they did it at 3 months. And of course, it would be interesting to see what this looks like longer term. I'm not sure if they're invoking that PFA has less degree of pulmonary vein stenosis down the line, but even with the thermal group, the actual number is very small. Looking at other reports in the literature, that even the negative 1.18 was not really significant when comparing that number in the literature.
Hey, Robbie,
good job, thank you.
Aparna?
Yes.
That was good. I see David DeLurgio was on that third reference there.
Yeah, he is.
So I would tell you that, that technique in which they have that little lasso loop on the end of the catheter, that technique, I think, was invented and developed by our own Jonathan Langberg.
Oh, really? Wow.
Did you find that out?
I did not know that, no.
So since then, the various iterations of that, and Jonathan envisioned putting it inside the pulmonary vein, and he used thermal. And of course, what Stan is referring to is the fact that we got pulmonary vein stenosis and had to stent those pulmonary veins. So the diagnosis of that is interesting. You know, in the echo lab, we would see increased velocities. We'd look for increased velocities coming out of that left upper pulmonary vein, which is the main one that Hesegera, you know, found had the little wavelets of atrial fib years ago when everybody first got on to where atrial fibrillation came from. So Jonathan needs a little credit for that. And I'm sure that he's got a patent for it, and he's probably still getting royalties from that, from the people who developed the pulse field ablation technique and all. So David's been involved with that, and then Jonathan has been involved. Jonathan, of course, was David's teacher, and a lot that work in part came from Emory. I just want to point that out.
Yeah, absolutely. Very.
All right. Well, fantastic. Thanks again, everybody, for tuning in. Thanks to Ryan and Aparna for their presentations this morning.
The preceding program is copyrighted by Emory University.